Uh, Thank you. Thank you very much, Roberto, and thank you all for all the speakers. I think we have still some 5 minutes left for questions, if everybody can turn off their videos, all the speakers, because then we can eventually ask some questions to everybody. Thank you very much for this great webinar, very challenging cases, just like it was asked, and indeed we got what we asked. Thank you so much. I have a complimentary question for Sorka from one of the people who attended this session and asked the question whether eventually a lens with an optic capture would have been an option.
I wouldn't have any experience in that, but it's very similar to the principle of the bag-in lens, but with less incarceration. The nice part about optic capture in a normal eye is that you have the stability of the sulcus with the positioning of the optic. You wouldn't have that in this case. So your sulcus haptics would sort of be almost free floating. So conceptually it would potentially work. But I think you'd be looking for a bit more stability in the bag-in lens approach.
Shading of the iris would be eventually a problem?
I'm not sure. I would wonder if the lens would be more decentered back. I'm not sure the haptics would be a problem. It's almost theoretical because I've never done it. If anyone else in the panel has experience in that, I'd be interested.
Yeah.
I have a little experience, but my case was actually a glaucoma case. So the cornea was very, very large, but the capsular bag was normal. And so I implanted the lens in the bag, simply.
Yeah. The bag, of course, is one of the structures that we cannot measure yet. We do not know the dimensions of the capsular bag. We do not know how large it is in the population. And that is still a little bit a drawback. But on the other hand, okay, it is most probably it will come that we will have those options very, very soon, I guess. I think that maybe another question, or if please, for all the speakers here, feel free to ask a question if you raise your hands, and so that we can have questions. I'm sure that Sorka has some questions for the different people speaking about the cornea. What I'm, for example, for Pavel Stodulka, Pavel, I must say, I was just like you are, very enthusiastic to do such kind of surgery in the past, thinking that it will most probably will help the patients. Yes, it does help the patients for a couple of years, but it will not help the patients till the end of their life. And I think that this is one of the other questions that I would like. Of course, you do not have the follow-up, long-term follow-up. You don't have it because these techniques, in fact, the technique that you are using is a little bit an adaptation of the Klaus-Egger technique of the corneal, the temporary corneal implantation that he used during vitrectomy in difficult cases where he also had opaque corneas, and that has been adapted quite a lot of the times, and I think that he merits the credit of that idea, because I think that it is his idea. And but on the other hand, it is nice, it is fine. We even could imagine quite a lot of other options, but ultimately we do know for such kind of surgery that it is a kind of prolongation or giving back a certain vision, but for how long? And that is still the question.
I think you are more or less talking about long-term risks of artificial corneas, which are certainly here and being mainly endophthalmitis and glaucoma. But having said that, although we did lose some of the eyes, or I would better say vision of some of these eyes implanted with artificial cornea, our first case, it's almost 15 years, she still can see. And we have several patients like that. So some of them really can have long-term vision, and for them, you know, that's the only hope, and that's something tremendous for their lives. But we are in need of better and safer artificial corneas, and there are teams working on that. So hopefully we will get them in the near future. And regarding the temporary silicone cornea, definitely they were there, and they were invented for pars-plana vitrectomy. They were adopted for cataract surgeries. Also, our proprietary approach is that we created that entrance before the surgery at the side, because the silicone is thicker, and if you just use your slit knife to make an incision for phaco probe, it would not really slice in and out as it would through the eyeball wall. So we need to adapt it somehow, and then it works quite well. And I definitely prefer to perform this surgery on a closed eye as long as possible, because the open sky surgery, I think, has, you know, significant risks.
Yeah, of course. Yeah. Roberto, if you have questions, don't hesitate. For the people, I have quite a lot of questions remaining, but I would also like to give you the opportunities.
Well, I think we saw different surgeries, and this is exciting of this particular webinar and of these particular people you hired tonight. So the questions are always, how can we replicate such beautiful surgeries in our operating theater? Because we saw expert surgeons giving their opinion and showing their techniques, and we admire them. And I think that we should be encouraged to practice a little more surgery than we think we can do. If we don't go close to our limits, we will never learn. And this is the main lesson we got today.
Absolutely. Absolutely, Roberto. Thank you for these wise words. I would also like to speak about, I think that's what Tobias Nohan addressed. I'm not sure whether Tobias is still there, but I would like to comment on Tobias Nohan's presentation. I think that as long as we do not have a technique that gives you the opportunity to measure the visual, to measure really where our retina, what part of the retina is looking and is used for our visual acuity, we still remain with quite a question mark. There are techniques that are coming up now using the Henle fibers and the way that you could measure during the surgery your Henle fibers from the macula in order to center the lens based on that Henle fibers. But whatever you do, you need to have a lens that is independent of the capsular bag or independent of whatever, must be centered by the surgeon, and that a degree of freedom that I think you cannot have when you put a lens in the capsular bag. But that is future, and I think that now in the future we will have quite a lot of beautiful things that will come up in the next year.
Maria Jose, however, I contacted a few producers about giving a decentered intraocular lens for high hyperopia, for instance, and they said we will never produce it because the market is not ready. No. So we should also encourage the industry to give us better products for those of us who are enough brave to try them.
Yeah, absolutely. But yeah, okay, I think it is always risky cases. And I think also, Roberta, I think you will agree with me, rare cases, we have to study them more in multicentric way because they are rare diseases. And then we have to see, if we want to progress, we have to get those cases together, and we have to learn from everybody in order to see what is the best approach. Let us, I don't know, I think it is already 20 past 8. I think it is time to stop. We can continue and continue, and I think that we have so many questions left, but I think we must stop. And it is, of course, a lot of questions that will be raised based on this webinar that we can use for future courses, future whatever initiatives that we will take. And if nobody of the faculty would like to ask a question or would like to address something, I would like to thank you all and wish you very, very happy, and also to the audience, wish you a very, very happy end of the year and a very happy new year. In the family settings, I do agree, but they are lovely and they are absolutely worthwhile. So I would say bye-bye for everybody and thank
Bye-bye
for participating. Bye.
Bye-bye.
Bye.
Thank
Bye.
you.
Bye.
Bye. Thank you.
Bye.
Bye. Bye, John.